Thanks so much for the intro, and thanks for the opportunity to be part of this congress. So my name is Shireen, and I'm a general dentist from Perth in Western Australia, and I have a special interest in airway health and tongue-tie management from infancy through to adulthood. And so today I'm going to highlight the opportunities to promote airway health from infancy. Okay, so my interest in airway health really began with adults. It was out of frustration of my husband's snoring. So that's when I decided that I was going to learn more on how to make oral appliances for snoring and sleep apnea for adults, and why I decided to obtain a graduate diploma in this topic. I wanted to be able to help other spouses in the same situation. Okay. However, what I first started to realize is that with these dental devices or mandibular advancement devices, they really are a band-aid solution for a craniofacial problem in these non-obese patients. We know that narrow high palates and retruded mandibles are a very well-known risk factor for developing breathing problems. And I wanted to know, how come we can't intervene with this in growing children? So this is a typical adult airway patient that has very common patterns of symptoms that I see. She presented to me with snoring. Her partner had moved out of the room, witnessed apneas. She's unrefreshed and waking. She's got a constant state of tiredness and brain fog, and she's prone to throbbing headaches once a week. She has chronic neck tension, and she struggles to breathe through her nose. So when I look at her, I see that she has a very narrow V-shaped arch. And as a dentist, I can see that she's missing premolar teeth, because as a youngster, to address this crooked teeth, she had premolar teeth removed and those spaces closed. We can also see that she has restricted tongue mobility or a tongue tie, and we can see some dorsal dimpling, which is a very good sign that she's not able to lift or suction her tongue. And so when we check her history, I can understand that she's had breastfeeding problems from when she was an infant. Her mum was not able to breastfeed because there was a lot of pain, and she snored from a very, very young age. And even at age 20, to help manage her symptoms, she was advised to take ADHD medications, which she declined. And so what I see here is some missed opportunities to help develop her jaws and also the way that her mouth has functioned. This situation is very much like a 6-foot tiger in a 3-foot cage, where we have a large tongue within a small mouth, and this creates a lot of stress, particularly at nighttime when we're sleeping. And so the first missed opportunity for her was really looking at the palate. And what is the significance of a narrow palate? Well, when we have a narrow palate, we have a narrow nasal floor, and this equates to narrow nasal airway and increased resistance to nasal breathing, and increased collapsibility of the throat. It also means that there's less space for the tongue to fit, and also reduced support for the soft palate. And so really this narrow palate influences the most common sites of airway collapse, which are the nose, difficulties breathing through the nose, as well as the soft palate and the tongue. And so we know that palate expansion in childhood has the potential to improve nasal breathing and reduce sleep disordered breathing also. And so when I look at palate expansion, a lot of the time the traditional age is to begin around the ages of 7 to 8 years. And so this is a patient that I commenced palate expansion at age 6.5 years. Her name is Jasmine. And again, very common patterns of symptoms that I see in my younger airway patients. She's had speech therapy fortnightly for 3 weeks without much progress. She's got behavioral concerns and is seeing a psychologist for an ADHD diagnosis. She had her adenoids and tonsils removed at age 2 to 3 years old, but there are concerns with persistent mouth breathing. She has daily tantrums, and her parents describe her as a monster after school, and they think there is a problem with the size of her tongue, and they presented to me for an orthodontic opinion. And so this is some progress photos of how she's been going during the process. We can see that she has a very narrow gutter palate, and I don't always need to wait until a child has such a narrow, severely gutted palate to begin treatment. But even within a few weeks, her parents reported she's closing her mouth more, her tongue is fitting better, she's got more solid sleep, so she's sleeping till 7 a.m. rather than 5 a.m, and she's got less tantrums, and she's speaking clearer. And so what I'm finding is that when we address the narrow palate, quite consistently, children are sleeping better. So no longer having to wait until the age of 7 to 8 years, I'm quite comfortable intervening for children as young as 3. Anytime there's a problem with their tongue space and there are functional concerns. So on the one hand, her parents are quite happy with the progress that she's made, and they're really happy with the changes in her facial appearance. And these are some photos that she's been sending to me. So this was on the first day when the palate expansion was introduced, and then on the most recent visit. And we can see there's been a big change. But I still question, could we have intervened earlier? Because there are still some behavioural concerns, and they are looking at getting a diagnosis or investigating ADHD. Now, if we look at this landmark study by Karen Bernach of 11,000 children, what they found was that children with sleep-disturbed breathing or symptoms such as mouth breathing, snoring, and gasping during sleep that peaked around 30 months had double the risk of behavioural problems, including hyperactivity, by the age of 7 years. So what we really need to be focused on is identifying this risk factor very early on in life and seeing what we can do to modify it if we want to help children get more restorative sleep during those critical early years. In 2014, I went to a pediatric sleep conference where Dr. Christian Gimino was there. He's a pioneer of obstructive sleep apnea. And I approached him at that time and I said to him, his work on palate expansion has really inspired me to learn more and to be able to offer this to children. And he made the remark that if you're doing palate expansion, you're too late. And at that time, I really had no idea what he meant, but it was a really important teaching moment that inspired me to keep looking for more answers. And so what I now understand is that what he was saying was when we have these sleep disturbed breathing problems, it's really a problem of abnormal collapse of the upper airway. And it is our jaws that form the structural support. So we need to pay attention to how the jaws are growing. 60% of the face is grown by the age of 6 years. So we need to pay very close attention in the very earliest years of life. But if its form, how the muscles work, influences how the bone grows. And so we really need to pay very close attention to how the muscles are working. So when I showed you that patient earlier, Jasmine, who we did palate expansion for, we can see that there are clues of oral dysfunction from the earliest years of life. We can see at 2 months, 11 months, before her adenoids and tonsils were removed, and after her adenoids and tonsils were removed, there is some oral dysfunction. And so we see from her history that she's got open mouth posture, low orofacial tone. She was breastfed for 18 months. But there was recurrent mastitis. So I know that her tongue suction was not effective and she was not draining well. She used a dummy for 3 years. She has had sleep disordered breathing, problems with chewing and swallowing meat, and a tongue thrust impacting her speech. So one of the key take-home messages is really when we have myofunctional disorders or problems with sucking, swallowing, breathing, or chewing, this could be the earliest warning signs that we're going to have a future of airway problems. Now, in particular, when we're paying attention to oral function, the most important function that we need to consider is nasal breathing, because this is where we spend the most time during the day and during sleep, and it's those light, persistent forces of the muscles that have the hugest impact on the way that the face grows. So in nasal breathing, what we want to see is we want to see good tongue to palate contact. And here, the tongue can provide the proper scaffold for the upper jaw to develop. If the tongue is lightly suctioned, it provides, it stimulates the growth, much in the same way as the brain and skull grow together, the eye and the orbit grow together, the tongue and the palate should be a good fit. But if for any reason the tongue is down, for instance, with mouth breathing, with dummies, or with tongue tie, we're going to get no support to the inward pressures of the lips and cheeks, and that's how we get the V-shaped arch. From another perspective, if you can see the high tongue posture against the palate provides the broad nasal floor and broad palate, whereas the lower tongue posture, it's actually linked to the inward collapse or distortion, high arch palate and narrow nasal floor. The other thing that we need to think about in terms of function is breastfeeding, because in the first year of life, this is when the jaws are growing most rapidly. And so breastfeeding can have a very important mechanical benefit in helping the muscles coordinate and developing the jaw. So breastfeeding is sometimes known as nature's palate expander, because for efficient transfer of milk, the tongue needs to lightly suction to the roof of the mouth. And then as it drops, it creates a vacuum, and that's how milk is transferred from the breast. And this is in contrast to bottle feeding, which uses an artificial nipple, which is not as deformable. And so it alters the way that the tongue works, and it doesn't really rely on as much effort. The milk comes out more easily, and the baby is using their cheeks as opposed to their tongue and their jaw to extract milk. The other thing that's really important with breastfeeding is to pay attention to tongue tie, because if we know that the tongue requires good suction to effectively draw out the milk, if the tongue is restricted in its mobility, then we're going to have some problems. And these can play out very differently for different children. So if we can't get good tongue suction, there might be more lazy or falling asleep at the breast, or difficulties with weight gain, or mastitis, or difficulties with swallowing or clicking and swallowing of air, and reflux-like symptoms. When we can't get that good suction, a baby may compensate and use their lips and cheeks excessively, and they may be more shallow latching, and this can be perceived as gumming or actually nipple pain as well. And so we need to pay attention to tongue tie. And it's not just enough to think that breastfeeding is all about putting on good weight gain and not being painful. If we really care about how the airway is developing, we need to make sure that there are no compensations. So common things that I see in babies that give me a clue that things are not functioning well include milk remnant, so this white coating on the tongue. When we have two-tone lips or lip callousing or blistering, they could be an indication that a baby is shallow latching and excessively compensating with their lips and their cheeks. Or we may have these visual clues like cupping or bowling on crying, or the dorsal dimpling, which could indicate that there is restriction of the tongue from normal elevation. It is important to have good tongue suction, because not only do we need that for breastfeeding, but it's really important for good oral rest posture as well. And so in good oral rest posture, nasal breathing, what we want is the tongue lightly suctioned. When it's suctioned to the palate and the soft palate, we're going to get very smooth laminar airflow. It's impossible to mouth breathe. But in contrast to lowered tongue posture, or if the back of the tongue mobility is restricted, the back of the tongue is going to be more flaccid. The airflow is not going to be as laminar. It can go a couple of different ways. It's going to be harder to breathe, increased collapsibility of the airway, and we're more likely to have base of tongue obstruction during sleep. So there are now there are more than a handful of papers that are linking untreated tongue tie at birth to the development of snoring and childhood sleep apnea. And so it's really important to pay attention to this tongue tie when it's not working well during feeding and speech, and when we have these compensations, then we know that that tongue is naturally not going to work well for palate development and its most important role as an upper airway dilator muscle to help keep the airway open during sleep. Now, the key take-home messages that I want people to take are that airway problems that we see have their developmental origins in how the mouth works and how the structure is growing. And so oral myofunctional disorders, starting from breastfeeding problems to how a child sucks, swallows, breathes, chews, and speaks, are the very, very first signs of airway problems. And so lactation consultants, pediatricians, speech and feeding, and all other child health professionals, it's important for us to help spread word of this bigger picture. In addition, when we have orthodontic problems, it's a sign that the jaw is not growing properly. So rather than a cosmetic issue, we need to recognize the underlying disturbance in growth and the way that the airway is developing also. And so in the future, what's important is that we can all integrate, our professions can integrate better to identify these issues and help manage them better. And so that way, if we can identify and restore both abnormal form and function as early as possible, during a child's peak development of facial growth and brain development, it's going to help children function and breathe and sleep better. But it's also going to help those children, prevent them from growing into the adults with bigger problems. So I've raced through all these concepts quickly. If you need any references, this is my professional Facebook group called Airway Health for Kids. It's all about disseminating new research, connecting the dots, and promoting interdisciplinary discussions. And I feel, I'd like you to feel welcome to contact me if you have any questions as well. So thank you.
Thank you, Shireen. You covered a lot of ground there.
That's great. It feels weird talking to myself, so thank you so much. I'm going to stop.
And you really wonderfully connected all the dots on the tongue tie, and facial development, the position of the tongue, plus the influence, of course, of breastfeeding and artificial methods. Thanks a lot for that.
Thank you.
And highly encourage everyone to subscribe to the Facebook page, Airway Health for Kids, because that's where all of us get our literature updates as well.